Assalamu alaikum, everyone. Am I audible?
Yes.
Yes, ma'am.
Okay, so let's start. Welcome to the Neurosurgical case room. We are going to cover the anterior interhemispheric transcallosal approach today. I believe I could not remember the session that we did it in, but I believe that we have done the anterior interhemispheric approach for meningiomas. I think when we were discussing the Falcian meningiomas, we did go over the approach. So this is going to be a brief one, but there are some more interesting approaches which only become an option once you have gone through the transcallosal approach and you have gained the ventricular entry. So we are also going to briefly discuss them. Let's begin without any further ado. So there are certain indications. We all know that the anterior interhemispheric approach, which is followed by a callosotomy, let me write here. This gives us two options. We can either go to the lateral ventricle, or we can continue our journey down to the third ventricle. Depends where our goal is, where our pathology is, but it's an approach which does provide corridor for both of these. So the indications are going to be a mix of lesions or pathologies. I'm sure you're all aware of them already. Probably the most common ones, colloid cyst of the third ventricle. What I have seen in my practice, we dealt with the colloid cyst, usually with the endoscopy, but the institutes or the centers where neuroendoscopy is not an option, and then the anterior hemispheric callosotomy is a very, very good option for the colloid cyst of the third ventricle. Apart from that, the actual lesions within the lateral ventricles, like a central neurocytoma, given that it is not too big in size. And then we have meningiomas, certain low-grade gliomas, like there are pellucidic astrocytomas within the septum pellucidum. Sometimes craniopharyngiomas, we have these AVMs, and yes, septum pellucidum tumors like ependymomas or subependymomas. The problem is, I think we did discuss this yesterday. What is our limitation here? Because we are dealing with the corpus callosum and our total callosotomy is 1 to 2 centimeters. If a tumor is huge, it's very bulky, then this is going to be really, really difficult to complete a total excision throughout throughout this corridor. So it's an excellent approach as long as the lesion size is reasonable. Let me show you an image. So you can see a lateral ventricular image. This is a central neurocytoma. And this is lateralized towards the left-sided lateral ventricle with hydrocephalus. But this patient was operated via an interhemispheric approach, and it did result in a complete excision via the callosotomy corridor. So this is one example. This is another example. It's a relatively smaller lesion, which is within the folds of the septum pellucidum. Very easy to approach. All you have to do is make a small incision in the corpus callosum and then gain entry towards one lateral ventricle and take it out. Let's see. So the contraindications. Now this is something which can be a very good topic for debate, because some of these would be absolute and some of these would be relative, like they would vary from surgeon to surgeon expertise. If there are dominant bridging veins which are not letting you create an adequate enough interhemispheric corridor, then that is also a relative contraindication. Asymmetric ventricular enlargement. I feel this is a relative contraindication, even if some textbooks advise against using the anterior callosotomy approach. There are cases where successful surgeries have been done, even if the ventricular enlargement was asymmetric. So this is also a relative contraindication. Hydrocephalus is a problem. This is a problem that I would probably think twice before approaching any patient via a transcallosal approach if they had significant hydro, because they would be, the pressure gradient within the ventricles would be really high, and I would not gain enough space to create retraction without using a fixed retractor in the interhemispheric corridor. And those of you who have been listening to me for quite a few sessions, they would know I personally have never been a big fan of fixed retraction. It creates these micro contusions and puts a lot of pressure on the cortex. Dynamic retraction is probably your best friend, but it's really difficult to achieve good retraction and an open enough interhemispheric corridor if there is extensive hydrocephalus. And that is why, what is our alternate approach when there is hydrocephalus? What do we use?
Cortical.
That's right. That is why we use transcortical approaches, something we discussed yesterday as well. The problem, which is when we are doing transcallosal approaches, becomes a blessing when we are doing the transcortical approaches, because now this extensive hydro and increased pressure within the ventricles thins out the cortical mantle. So the distance that we need to travel for a transcortical approach, it reduces. One man's trash is another man's treasure. I think that fits perfectly here. Apart from that, if you're operating on a case where there is already some involvement of corpus callosum, then that is a relative contraindication as well. I have studied cases like this, and I have also seen some senior surgeons operating still, even if there is corpus callosum involvement. But I think this would be a surgeon's choice and still a relative contraindication. So let's come back. If you look at this image, this is an illustration that shows how just a small incision in the corpus callosum is going to be the gateway towards multiple options within the lateral ventricles and then within the third ventricle. You can see once we do a callosotomy, if it is slightly paramedian, you gain access to the ipsilateral lateral ventricle. From then, there are multiple options to go into the third ventricle. You can go via the foramen of Monro. Foramen of Monro cannot be seen here. This is visible here somehow. You can go via foramen of Monro. You can go interfornicial. We saw those images as well in a previous session. You can also go subchoroidal or transchoroidal. These are the approaches we will also briefly discuss towards the end of the session. Let's move on. But you get the gist how the anterior callosotomy is going to open the gateways towards the lateral ventricle and the anterior third ventricle. These are the surgical steps that we are going to breeze through. We put the patient in a supine position, we flex the neck slightly, and ideally we ensure that the sagittal suture is perpendicular to the floor so that we are anatomically oriented during the surgery. The incision and craniotomy varies, especially the incision. There are surgeons who prefer the linear incision for the anterior interhemispheric approach. There are surgeons who use the trapdoor or, the hinge flap incision, the U-shaped incision, and this is basically mostly a surgeon's choice. I have always used and seen used this incision, the trapdoor one, where, we base the incision towards the superior sagittal sinus. Whichever incision you are using, make sure you're going to mark the coronal suture and you're going to stay anterior to it. Let me see if I can draw here. For example, this is the top of the head. And this is the coronal suture. This is the midline. So our incisions have two options. You can either do an incision like this, or the other option is, let me change the color. The other option is to do, in fact, let's see the illustration and not draw here. What we do is we build a hinge flap, and then we reflect the skull flap, we expose the pericranium, we make a craniotomy. After we are done with the craniotomy, we make sure that at least 1/3 of our exposure is towards the contralateral side. I'm going to show the pictures, so if this is a lot of text, please bear with me. When we are only doing anterior interhemispheric approach for let's say falcian meningiomas, we do not need to ensure that we are anterior to coronal suture. But when we are going to do an anterior callosotomy, we want to be sure that our incision and our craniotomy boundary stays anterior to the coronal suture in order to not miss the portion. Let me see. This is the other option that I was talking about. So the superior sagittal sinus. And the other option is this is the coronal suture. You can make a linear incision, which is small. There are surgeons who would use a complete suture incision from one tragus to the other tragus for an anterior interhemispheric approach. I personally find that extravagant. A smaller linear incision is going to be just as good. The other option, which is my personal favorite, is this one. This is the hinge flap or the trapdoor or horseshoe incision, whatever you want to call it. You make the base towards the superior sagittal sinus, and then you flip it on the other side so that this entire thing is exposed. Let me show you the incision and the craniotomy as well. This is a smaller linear incision and a cadaveric section. And you can see the beautiful craniotomy, which has been based over the superior sagittal sinus. Superior sagittal sinus is just under here. Now, there are also variations in the craniotomy. Let me go back to the previous slide. The variation that I was talking about is different surgeons have different preferences. And also, it probably depends on the institution you have trained in as well. There are surgeons who would make burr holes right over the superior sagittal sinus and then create the space with the periosteal elevator and then make this the last cut. Then there are surgeons who would use the straddling technique. There's going to be a burr hole here. There's going to be a burr hole here, another burr hole here, and another burr hole here. 4 burr holes which straddle the superior sagittal sinus, so that you are not risking any injury to the superior sagittal sinus. Both of these work fine. This is more a matter of the surgeon's preference than a matter of being right and wrong. Once you have done the craniotomy and you have taken away the bone flap, the dura is visible, what you do is you make a dural incision here, making sure that you are not injuring any underlying bridging veins. And then you flip this towards the superior sagittal sinus. It does 2 things. A, it creates this natural space for the anterior interhemispheric corridor. B, it also protects the superior sagittal sinus. It's harder to injure the superior sagittal sinus. This is under the dural fold. Let me show you the images ahead. Once you open the dura, you can put the tuck-up sutures on the other side as well to create some tension and to keep your superior sagittal sinus safe. You can see here And you can also see some bridging veins. These thick cord-like structures are the bridging veins that you cannot sacrifice. And this is what we were talking about when we were saying that this can be a relative contraindication if you are operating. Keep yourself muted. I think someone new joined. Please keep yourself muted. So what happens is, once you flip the dural flap on the other side and you create this sandwich, I like to call it a sandwich, you put up tack-up or tension sutures to keep the dural fold retracted. This is a natural corridor. This is the frontal lobe, the medial frontal lobe. This is a natural corridor. You put a retractor and you go down this fissure, the interhemispheric fissure. On the other side, if you remember, there's fornix here. If you can see this portion here, this is fornix. This is the medial surface of the brain. In between them, there is a natural corridor, and the goal is to go under it. Now, once you retract it and you go under it, you're going to find two things. There would be some bridging veins, and there would be arachnoidal web or arachnoidal adhesions that you need to gently dissect with the help of sharp dissection and create this space. Let me show you the images a bit. So once we have separated the arachnoidal webs and gone down deep, the first structure that we are going to identify, and it probably would confuse us as well. There are two, let me draw. There are two things here. We have the corpus callosum in the red. And then on top of it, we have a gyrus. Can somebody name this gyrus, please?
Cingulate.
That's right. We have cingulate gyrus right over here. Now the problem is there are two sets of arteries and we have to identify both of these. There will be two arteries paired ones right on top of the corpus callosum, and then there would be arteries running right around cingulate gyrus as well. Can someone name these? Which ones would be on the cingulate gyrus?
Anterior cerebral arteries. A3. Pericallosal.
Okay, where would be the pericallosal? Okay, this is the yellow one. Which is the yellow one?
Pericallosal.
Okay, and which is the green one?
Callosomarginal.
That's right, callosomarginal arteries. So once we separate the interhemispheric fissure, the first things we will probably encounter if we have not retracted deep down enough is these callosomarginal arteries and the cingulate gyri. It's really important to not confuse this as the corpus callosum and, make an incision within it. A, you would be injuring the cortex. B, you would also be creating an epileptogenic focus. So we have to be very, very meticulous in terms of identifying the corpus callosum. Once we retract these beautiful gyri that close like lips, we are going to find corpus callosum underneath these two paired arteries, the pericallosal arteries, and we have to retract these to create a space between them for our callosotomy. I'm going to show the images so that it's... Are you all with me till this?
Yes. Yes, ma'am.
Okay.
Yes.
If you look at this, this is a zoomed in image of the interhemispheric corridor. In the first image, you can immediately see the corpus callosum body, but let me show you the cingulate gyrus. If you take a deep look here, there is going to be cingulate gyrus here, and along with the cingulate gyrus, you're also going to have the callosomarginal artery. Once you have retracted it deep enough, you can now see the paired pericallosal arteries, and underneath them, we have the whitish body of the corpus callosum. We all know the boundaries and the margins of the callosotomy. We have to keep it under 2 centimeters to prevent any disconnection syndromes, akinetic mutism, etc., etc. Please keep yourself muted. Okay, once you have entered the lateral ventricle and you have identified the choroid plexus, the thalamus striate vein, now depends where your pathology is. Assuming it was in the lateral ventricle, then you can proceed for the orientation first and then for the debulking of the lesion and hemostasis. If your goal was to enter the third ventricle, then there are 3 access routes: foramen of Monro, a transchoroidal approach, an interferential approach. In fact, there are 4 routes. I forgot to write the 4th one here. There is a subchoroidal route as well. So when we are discussing these different routes, since I don't want to dedicate a separate session for these, we have discussed this before. Once we are going transforaminally, there are 2 problems. The first problem is, if it is not naturally enlarged, then we end up risking injuring the fornix, because we know this was the boundary of the foramen of Monro. We have seen this thoroughly in the previous sessions. This was fornix here, superiorly, anteriorly, inferiorly we have thalamus here. If this is not naturally enlarged, then you are not going to find a lot of space to enter the third ventricle. If this is a patient with hydrocephalus already, or if this is a patient with a colloid cyst, then the foramen of Monro will be enlarged. The transforaminal approach will be a relatively easier approach to do. Otherwise, you end up risking damaging this fornix if you retract or if you stretch too much while entering in this route. The other option that we also discussed previously was the interferential approach, where we were splitting the body of the fornix and we were going right in the middle, landing in the middle and the posterior third ventricle. The 2 approaches that we did not discuss at all were the transchoroidal and the subchoroidal approach. Let me see if I have the image. Okay, so this is an axial section and it shows all the structures. More importantly, it shows where we can go. You see the foramen of Monro here. You also know that there is fornix here and there is thalamus here. The projection of thalamus is visible. On the other side, what you also see is this is all fornix. Let me mark first so that this is the choroid plexus. We have 2 or 3 options here. Let me choose a color that would be visible. I'm using red to mark the corridors. We have established the interferential approach and the foraminal approach, right? The other 2 corridors are going to be here, between the choroid plexus and the fornix, and between the thalamus and the choroid plexus. Am I making sense? Or do you want me to draw this again? Am I audible?
Repeat, ma.
Yes,
Okay.
ma'am. Draw it again,
I-
ma'am.
I will. We have thalamus. Let's show you. We have thalamus here. After thalamus, we have the choroid plexus here, the choroidal fissure as well. And around it, we have the fornix. You're all with me so far?
Yes.
Yes, ma'am.
Now I'm using white color to show you the corridors that can be used. The pink one is the choroid plexus and the choroidal fissure. The orange one is the fornix. If I go between them, this is one corridor. If I split it open, retract, and then go between them, this is one corridor. And the other corridor, the other option is to go between the thalamus and the choroid plexus. Let me repeat myself. If I go between, this is the thalamus, this is the choroid plexus. If I go between the thalamus and the choroidal plexus, then this is a subchoroidal approach. Mark. This is a subchoroidal approach. If I go between this fornix and the choroid plexus here, then this is a transchoroidal approach. So more or less the same thing. The only thing that is going to be different is the structures that are surrounded by it, because that will decide how much of the venous exposure we get and how much of the retraction we can do, the working angles and stuff. Let me repeat myself again. If I go between this space, between thalamus will be retracted slightly laterally, the choroid plexus and the fornix will be retracted slightly medially. I will create a small space here and go down it. This has the benefit of lesser chances of venous injury, and the con is that the working angle would be very difficult. But if I go here, the working angle is better. I would be able to retract more, but the problem is that the risk to major veins would also be higher. Am I clear?
Yes, ma'am.
Let me see. We can have a follow-up session in discussing these approaches because they are obviously slightly complicated, and we would need some dedicated time to discuss them. But I thought it would be interesting if we also discussed these corridors towards the third ventricle while we were discussing the anterior callosotomy, because anterior callosotomy is very straightforward. It's probably one of the easiest approaches to teach. This is the interfornical approach, the fourth one. We have discussed this enough number of times by this point. We open up the bodies of the fornix and we land into the third ventricle straight forward. And yes, there is chances of venous injury, especially to the deep venous system. And there are chances of injury to the fornix. Let me see. This is what we are going to do if the target lesion is within the lateral ventricle. We are going to debulk and resect the lesion, and the goal is to maintain meticulous hemostasis. We are going to leave the area meticulously hemostasized, along with using warm saline and gentle coagulation on very, very low current. Once we have done this, we retract all the instruments that we have used, and we close the dura watertight because obviously we have opened the ventricles. We don't want a CSF leak postoperatively. Then we replace the bone flap and close the scalp in anatomical layers. These are the illustrations that show the, and this one is, which approach is this one? Between the fornix and the choroidal fissure. Somebody wrote in the comment and they were right.
Right, yeah.
That's the transchoroidal.
This is a transchoroidal approach because this is opening the corridor between the fornix and the choroidal plexus. Whereas if the same corridor was here, then this would have been a subchoroidal approach. We can have a follow-up session tomorrow for these two approaches, inshallah, if you want me to. It's the same thing that we have discussed so far. If I go here, and this is a subchoroidal approach. If I go here, then this is a transchoroidal approach. And if I go somewhere in between, then that would be an interfornicial approach. That's it. This is a wrap for today. Any feedback, any questions, all of them are more than welcome. Please let me know on the group if you want a follow-up session for the transchoroidal and subchoroidal approaches. We can have a separate space to discuss them. Thank you so much, everyone. This is a wrap for today.
Thank you, ma'am.
Thank you.